Welcome to this month's Respiratory Care video abstract. I am Lynda Goodfellow and one of the journal editors, and I'll discuss Jessica Patel's paper of establishing excellence for the newly licensed respiratory therapist. The aim of this project was to evaluate the feasibility and the effectiveness of a residency program for licensed respiratory therapists with less than 1 year of experience post-graduation. The approach to improve new graduate transition to practice included a streamlined clinical-based orientation, didactic learning, evidence-based practice plan, and incorporating simulation. There is little evidence in the literature about a respiratory therapist's transition to practice and what resources they may need. So Patel and her colleagues sought to create a respiratory therapy residency program at their workplace because the workforce was stressed during COVID-19. It was noted that there were differences in the way that respiratory therapy students were trained and how they gained clinical experience, forcing the organization to take an initiative to improve their clinical onboarding process. In the literature, a recent study by Pisuto and DeSantis Santiago identified that out of 28 new entry to practice graduates from May 2019 to December 2021, a significant number experienced barriers such as limited clinical experiences and a lack of exposure to skills and procedures. This impacted their confidence. This added to their feelings of stress, being overwhelmed by work assignments and exposures to negative behaviors in the workplace. So the aim of the Patel study was to increase the confidence, the satisfaction, and the competency of their new entry to practice graduates. And so they were invited to participate in the respiratory care residency program. And inclusion criteria were that they had less than 1 year of postgraduate experience and they were across one large healthcare system. The study was IRB approved and was a longitudinal cohort research design. A convenient sample of two cohorts, one with 20 subjects and the other were 14, were formed. After 6 months, there was a post-implementation assessment. Eligibility criteria were that you were graduated from an accredited respiratory therapy program, less than 12 months of work experience, had your RCP license and American Heart Association certifications, and was a certified or registered respiratory therapist. There were residency requirements to fulfill. One must work towards a formal or informal leadership position, make academic progression towards a higher degree, and continue your professional development by presenting at conferences, participating in a unit council, or an evidence-based project. There were also metrics for effectiveness, and all the participants had to meet these requirements by the 6-month timetable. 90% retention rate was expected within the first 2 years, and to complete a professional development opportunity within the first 3 years. To describe the participants, 19 or about 68% held an associate's degree, and many of those also reported prior experience as a licensed RCP. Of the 34 subjects total in the residency program, 24 had obtained the registered respiratory therapist credential and 10 had obtained the certified respiratory therapist credential. Orientation time ranged from 1 to 143 days with a median number at 76, which equates to about 2.5 months per orientation time. 2 competencies, the communication and leadership, were found to increase from baseline to almost 13%. But a slight decrease in professional skills was observed, mainly in those in the pediatric population and who had a longer orientation length of time, which decreased to 0.5%. Participants were surveyed and their responses were self-reported in that they had an increased role confidence level, clinical skills were higher, and that they had a better understanding of knowledge-based topics. 91% of the residents still worked at this hospital system at the time of the submission of the paper to respiratory care. There were other metrics besides the CRT versus RRT and retention rate, but they also looked at the projected expense of the residency program versus the actual education and salary of the participant, the percentage of time to completion for orientation, as well as employment tracking. But throughout this process, they always provided anonymous surveys to the participants so that they could assess their general satisfaction of experiences, comfort, and confidence levels so that if there were changes needed into the program, that they could do those quite quickly as opposed to waiting till the end of the program. In conclusion, Patel and others suggest that RT residency programs support transitioning to clinical practice and improving patient care. But future studies are needed to show a greater correlation and increased confidence in residency programs. And in fact, the question is, which are better, residency programs or rigorous onboarding orientation programs? Besides, there's also a limitation of residency programs in the rural areas, because most residency programs that are known are in urban large hospital systems. The other limitations include a small sample size for this particular paper, and the data regarding outcomes are self-reported. There are also less than 30 subjects in the first two cohorts, and this generally leads to increased bias whenever you have a small sample size and small cohorts. Thank you for listening.